Good morning. How are you, everyone?
Good morning.
Good morning.
Yeah. Okay. Can you see this ECG on with this one here? Yeah, you can, right? Yes, no?
Yes,
Yeah.
yes.
Okay, good. Give it everybody. Let's give it 1 minute and then we'll get going. Mohammed, are you back from California?
Yeah, I just arrived at 2 a.m.
Very nice. All right, why don't we get going? So this is an electrocardiogram that was just this morning sent to me from my friend, Dr. Savli, who is a pediatric cardiologist in Vietnam. And Dr. Savli often will share interesting tracings with me. So this apparently is from a 5-month-old who had Tetralogy of fallot repair a number of weeks ago. And his question to me, I'll read it to you. It just came across this morning. He said, this is a 5-month-old, had Tetralogy repair. And I observed this weird QRS morphology. Everything is well. She's extubated on day 2, stable hemodynamics, no arrhythmia episodes. But the EKG has this unusual, what he refers to as a polyphasic fragmented QRS, right bundle branch block, sinus rhythm. Would this EKG predict serious arrhythmia events in the future? And if so, how should we manage this? So this is what Dr. Savli had asked. So I'm going to pose this question to our esteemed panel here. Let me see. Let's see, Dr. Bonsall, what do you think about this tracing and Dr. Savli's questions? This comes to us, by the way, from Cantha Bopha Children's Hospital in Vietnam.
Good morning, Dr. Paz.
Right.
So it's sinus rhythm, and obviously his question is specific to the bundle branch block, which is seen commonly in patients after tetralogy of fallot repair.
Yes.
Um,
You're speaking very softly. It feels like you're trying to not wake someone up in the room.
no, is it better?
No, that's fine. That's fine. Thank you. I'm just, no, I'm always kidding with you, Perna.
What did he want to know about the right bundle branch
Well,
block?
he wanted to know if they should be more worried about serious events, arrhythmia events in the future as a result of this this finding. I mean, let me ask you this: is this a usual morphology in your experience? Yes, no?
Yes, after tetralogy of fallot repair, yes, very commonly see right bundle branch block.
You can see it, right?
Mm-hmm.
Okay. Is there anything else about it that's a little unusual?
He said polymorphic, right?
Polyphasic. Yeah, I don't exactly know what that means, to be honest.
Okay. Okay, I was wondering what to make out of that.
Well, what do you think about what? So he's asking really more of an interesting question. So the other thing, of course, is it's a rightward axis, right? So that we see sometimes after tetralogy repair. So what are we worried about? So you are now the cardiologist. You're out in Florida. This patient has had surgery and
so I mean, overall QRS duration is something that you look for and a QRS duration of more than 160 has been known to have, like, overall in long term, your QRS duration of 160 is concerning for a higher mortality in future. Like, if you've reached that, that's when we start discussing about pulmonary valve replacement.
Okay. So
Mhm.
you're conflating two different things. Your pulmonary valve replacement, you mean because of RV volume dilation? Okay.
But so that is implicated as one of the risks of sudden death in future, a
Right.
prolonged QRS duration. Here, I think it's 120 milliseconds. 1, 2, 3, or 3.5.
Pretty wide.
Yeah.
It's pretty wide. I mean, it's not that wide, but as we know, it gets wider with time. So
Mhm.
some studies have shown that, but interestingly, not all. And there are a number of different studies that have supported the QRS duration as a risk factor for sudden death, and VT in patients with tetralogy. But then there are also some studies that have not suggested that. What other things would you be concerned about in terms of worry for risk of sudden death in this patient? So let me ask you, let me take a first step. So Dr. Safley's like, should we be worried about this patient? So I think we would agree, probably on average, slightly higher risk for arrhythmia than the average tetralogy patient, but probably not a lot more risk. And probably we would not follow this patient any differently than any other tetralogy patient. But what would you do and what would worry you as you're following a tetralogy patient? First of all, when tetralogy patients have sudden death, when is that usually an issue?
When they're
In the course of
adults.
their life. When they're what?
Adults.
That's right. It's very unusual in pediatric practice for a tetralogy patient to have sudden cardiac death. So it is much more of an adult problem. And as is the case in virtually all ACHD arrhythmia, the longer you are out from surgery, the greater the risk for serious arrhythmia. Okay, so you are now running your own new ACHD clinic, and this patient is in your clinic. So what are you going to do to monitor this patient, and what would be the things that would potentially concern you? Well, we've talked about the duration of the QRS. So
duration of the QRS, then we serially follow them with Holter monitors, like you said, for arrhythmia. Then we also look at their function as well as their volumes. For initially with echoes, since when they're babies, it's doable, but as they get older and the windows get limited, then we go for MRI.
And does the volume have any known association with risk for arrhythmia or sudden death?
So the volumes have not been implicated directly in terms of sudden death, but the volumes do give an indication as to when to go for pulmonary valve replacement. So an RV EDVI of more than 160 ml per meter square is what we say is usually the cutoff for the pulmonary valve replacement.
Okay.
And then RVES, I am forgetting if it's 80. I don't remember the absolute number.
So, but what other things are you worried about? Like, so you would do a Holter, or which is better, by the way? Is it better to do, say, a 48-hour Holter, or to do, say, a 7-day ZO in these patients? Are there any data to suggest that one might be superior than the other in the ACHD patient?
I am not sure about that, but we use ZO at our place in our clinic, so I would say ZO.
Well, it turns out that a paper written by Scott Sereznak and his colleagues in California looked at this exact question, whether
Mhm.
or not monitoring beyond 48 hours, which is the standard upper limit that you can do with the Holter, is better. And it turns out that about 40% of the time, the clinically significant arrhythmias were identified after 48 hours.
Mhm.
So probably there is some utility to doing longer monitoring in these patients. And thankfully, with monitors like Zio or Barty devices, patients are not as bothered to wear them, and so they tend to have better compliance. Now, it isn't clear yet whether if you identify something on the 8th day, if that is in fact a worrisome finding. It sort of makes sense that it would be, but on the other hand, in the past, we had lots of patients who only had 48-hour monitors. We never saw these arrhythmias were identifying later on the monitor. And to our knowledge, most of those patients did well. But I think it makes sense that if you find something that would worry you in the first 48 hours, it should probably worry you beyond 48 hours. So probably longer monitoring is preferable if possible, but not critical, or at least not proven to be definitively better. Okay, so you've done that monitoring. Anything else that would worry you when you're seeing a patient in the office, you're worried about sudden death. Dr. Savli told you 35 years ago that this patient's QRS was wide. You're now seeing them in the office at age 35. The QRS is similar. Is there anything else about the patient that would worry you?
In one of the recent papers, a history of having a shunt as the initial repair was also implicated as one of the factors
Yep.
for sudden cardiac death.
Mhm.
And if there is an inducible VTAC on an EP study, then that is also a factor for sudden cardiac death.
Yeah, that's certainly true. But of
Mhm.
course, you have to do that. And we wouldn't
Uh-huh.
do EP studies just on everybody.
Right. Mhm.
The other two things that I would mention that are very important
Mhm.
is a history of symptoms. If a patient with
Yes.
tetralogy is complaining of palpitations, that is a group where you should take that symptom very seriously. That actually, in a recent large-scale study done by the group in Boston about a year or two ago, was shown to be a very substantial risk factor for the development of for ventricular arrhythmias in tetralogy patients. So if the patient is complaining to you, you should aggressively surveil that patient because there's a reasonable chance it may be real. The other thing that's very important, interestingly enough, is LV function.
Mhm.
Okay, so LV function in many different studies now is coming out as perhaps the strongest predictor of ventricular arrhythmia and sudden cardiac death in the tetralogy patient. That is not an obviously intuitive finding, that the LV in a tetralogy patient, which is of course an RV disease, would be a predictor of problems. There is this concept in the adult world called the Bernheim effect. So in the Bernheim effect, the most common cause of bad RV function is bad LV function. So bad LV function causes a ventricular interaction. But when you have tetralogy, you could have a so-called reverse Bernheim effect, where the RV is negatively impacting the LV. So anyway, interesting observation. So we want to fix our RVs. And I, although you quoted for us those numbers, which are correct in 2022, I do think that as transcatheter valve technologies improve, it's likely that our number or our standard for when we intervene to replace the pulmonary valve will become lower, will be more liberal, because as the ease of the procedure improves, it's not clear to me what the benefit of allowing patients to sit with volumes even that large is. I think when the concern is, or the alternative is surgery, we would, appropriately be concerned about not proceeding with surgical repair unless taking that risk, unless there was a very large volume. But I think with time, we're going to find that probably we're going to end up intervening sooner over time. All right. I thought that was just interesting things. So here we go. All right. I received this text recently. It says, "Good morning, Dr. Pass. The ECG is from an 18-year-old female with no past medical history who presented to the ED with chest pain, found to be an AFib with a ventricular rate of about 100. Has had 4 visits to the ED urgent care over the last few months for chest pain and palpitations. Has always been in sinus at those visits. Current episode started at 7:30. And the question is, this was patient presenting to an outside hospital. Do you think we should transfer to our hospital? Or is there something there are recommendations that we can send to the ED so that we can manage there?" This is the tracing that I was sent. And I'm going to ask Dr. Sergey Bebia, what does he think about the questions that this excellent fellow asked of me at 5 in the morning.
Good morning.
Good morning.
So looking through the EKG, all right, so we're seeing a regular rhythm. It's obviously not sinus. And in some of the leads, it looks like there are atrial flutter waves. Honestly, I think, like in AVL, for example, or lead 2. So the questions that are asked.
So the first question is, what rhythm do you think this is? Do you agree with the texter that this is AFib?
I wouldn't agree. I would say it could be atrial flutter.
All right. I actually think this is fib. You know, in the old days, people would refer to this as fib flutter, where you see something that looks flutter-like. I agree that an L, this kind of looks like flutter, but I think in other leads, it looks more disorganized. Like, look at this area here. This would be a very, very fast flutter. And if you really think it's flutter, you'd have to say that the P to P interval is fixed. And I don't actually think it is. I think it's hard to tell without the tracing being in front of you, and this tracing's quality is suboptimal because it's probably a text from someone else being sent to our fellow who's then sending it to me. But I think this is probably fibs. I think the fellow is correct that this is fibrillation. So the question is, you know, they want to know, does the patient need to be transferred to our center, or can they manage this in the emergency department? So what do you think about that? What should we do for this young lady, 18-year-old lady, who's in some kind of atrial fibrillation?
Right. So we would do an echocardiogram. The only thing is that I see in the text it's mentioned the start of these palpitations, 7:30 p.m. And what time did you get this message?
This is about 10 hours later.
Right. So on one hand, we want to make sure that while she was having this irregular rhythm, that she didn't form a thrombus. On the other hand, having I guess this irregular rhythm for only 10 hours probably is not the highest risk for thrombus formation. But
What's the line in the sand? I agree with you.
24 hours, I believe.
Yeah, at about 24 hours, the risk starts to rise quite high. Under 24 hours, the risk is very low. And you talked about getting an echo. Is a transthoracic echo a good way to rule out a thrombus in somebody who has an AFib?
Not in an 18-year-old. It should be a transesophageal echo.
What about in a one-day-old?
Well, in 1 day old, you wouldn't be able to do a transesophageal, and I think transthoracic is a pretty good
So
way
the
of
answer
looking
is,
for it.
you're right that a transthoracic is better in a 1 day old than in an 18-year-old, but we can never rule out the presence of a small thrombus. Where's the most common place that thrombi occur in people in AFib? Like, what are we most worried about? Where if you were doing an echo and you only had 5 minutes and they said, I want you to try to rule out the presence of a thrombus, where would you look first?
Atria.
Right, but where in the atrium? There's actually a particular place that's particularly worrisome.
This is the appendage.
Which appendage? The right appendage or the left?
Left atrial appendage.
Right, the left atrial appendage is a very high risk. That is by far the most common place that thrombi exist. And I'm sure you've seen there's an entire industry being developed to close the left atrial appendage. And in fact, some surgeons at the time that they do coronary bypass surgery or any kind of heart surgery will amputate the left atrial appendage in order to reduce the risk for thrombus. In fact, some older patients, when they have AFib, as you know, most of the anticoagulation is risky in an older patient who could potentially fall and bleed. And so sometimes they'll just recommend closing the atrial appendage or amputating it as the sole therapy rather than anticoagulation, because the risk for thrombus in the left atrial appendage is so high. In fact, just today on LinkedIn, I noticed this morning at 6:30 that our local rep from Abbott proudly put on that Dr. Reddy used a special new sheath that they've developed for a left atrial appendage closure, a deflectable sheath, and how proud they were. It was the first use in the United States. So the point I'm trying to make is that a transthoracic echo is never an adequate way to rule out a thrombus. It can rule in a thrombus. So we always do an echo because if we saw something that was obvious, then that would, of course, it's very good if it's positive, not so good if it's negative. Okay. So the patient's in the emergency room at a hospital outside. Do we need to bring this patient to our hospital? Can they manage this in an emergency room? How would you decide this?
Well, if they can do sedated cardioversion, then and they can do an echo.
Have you ever worked in an emergency room that does that with any regularity?
Not in the United States.
That's okay. Good answer. Not in this country. No, not usually. Although ERs, of course, are used to sedating people, they would rather not, right? If they didn't have to. So, okay. So
the answer is yes. We should transfer this patient.
Yeah, the patient needs to be transferred because if this persists, you would probably want to. The other thing is, this is important. A lot of times people who have AFib or atrial arrhythmias will say to you that it started at a particular time. But sometimes I'm always worried about that history, because when a patient's ventricular rate goes below 100, they often think they're no longer in their arrhythmia. And when they have a rapid ventricular response, they feel that they're in their arrhythmia. So sometimes when their catechol levels rise, like they climb 2 flights of stairs or something, they'll start feeling their heart beat rapidly and say, oh, I just went into tachycardia, but they may in fact have been in it already. So you always have to take with a grain of salt when a patient tells you exactly when they went into it. But okay, so you transfer the patient over from the other hospital, and this is the arrhythmia. So what would you do, Sergey, in evaluating this patient? Or managing this, I would say.
All right, so once she's transferred and we adequately sedate her, we should do synchronized cardioversion.
Okay, so let's pretend that we're in the real world, and it's 6:15 a.m. And you know you're not going to be able to cardiovert for at least 4 hours because you have to round in the ICU. And you'll be lucky if you can attend to this patient by 10, 11 o'clock at night, in the morning. So
Right, then
what are
you
you going to
start
do for the
heparin.
patient? What are you going to do for the patient in the interim?
Right, then you need to anticoagulate her, so you'll start a heparin drip.
Right. Exactly. And what would you do? Do you need any anti-arrhythmia medicine of any sort?
I would probably, if she's hemodynamically stable, no, I would try cardioversion first. And then if that is not successful for a long time, then I would think about studying her in antiarrhythmics.
Do you think the patient would be stable with the EKG that we're looking at here?
I mean, her heart rate is somewhere in between 100 and, I would say 100 and 170, no, less than that, 150 probably.
Right.
So, I mean, I wouldn't be surprised if she's hemodynamically stable.
Yeah, some of the RRs are even longer, right? Some of them are like a rate of 70. So yeah, so this patient we would expect would feel okay and would be stable. So yeah, exactly what you said. We would anticoagulate this patient, and then we would do a transthoracic echo because it would be, at least useful to tell if there was a big thrombus there. Similarly, you'd want to know if the function was affected because that might affect how you sedate the patient. Right? If this patient was chronically in AF and had a chronically elevated ventricular rate, you could have a tachycardia-induced cardiomyopathy, and you would want to know that the patient's function was okay before you gave certain agents to sedate for cardioversion. Okay, and then the next question then is, so this patient spontaneously terminated, went into sinus rhythm. And so I'm going to see this patient in the office for follow-up. So what do you think I should do, Sergey, when I see this patient in follow-up? So they're going to come into my office and presumably they're in sinus rhythm. By the way, is there anything, any testing you would want to do on this patient when they came in with the AFib? Anything you think could cause AFib in this 18-year-old girl?
Well, I mean, obviously, even if she comes in sinus rhythm with this history, I would do an echocardiogram to see if there is any.
But when you're first meeting this patient, let's say the patient is in fib, they transfer her from the outside hospital ER and she is in atrial fibrillation. Is there any blood work you might do in a patient who's in fib?
Should we check her thyroid function?
You could check her thyroid if she were hyperthyroid. That could be associated with AFib. Any toxins can cause AFib?
Right. Yes, they can.
Uh-huh.
Which
Any
ones?
common ones that 18-year-olds might be forced to drink or eat or be exposed to?
Alcohol.
Alcohol. Alcohol's a very common cause of AFib. In fact, emergency rooms often are very busy, for example, on nights where drinking is common, such as New Year's, so-called holiday heart. So you would definitely want to take a good history and probably get an alcohol level because AFib can be triggered by excessive consumption of alcohol for sure. Okay. So now the patient is in sinus rhythm. You observe the patient overnight. They remain in sinus rhythm. You discharge them from the hospital and you say, well, follow up with Dr. Pass in a week or two. So they come into your office, they're in sinus rhythm. What do you think I should do? What should I be concerned about? What should I be monitoring? And then first of all, what should I tell the patient is their future? Are they going to have AFib again?
Well, if there was no trigger associated with this event, like again, alcohol intoxication, then I guess we need to send her home with a Zeo patch and see if this was a single event and she doesn't have any rhythm issues in a
Okay.
longer
So we
period.
do a 14-day ZO and it is completely negative. But like she asks, her mother asks you, Dr. Pass, Dr. Bebbia, is my daughter going to continue to have this problem? What do you think is the likelihood that she has another episode of AFib?
Well, I am not sure, but I guess if she had it once, she has a higher risk than general population.
Yeah, actually, this is what we would call lone AFib. And once you have it, you pretty much have it. There's a very high chance it's going to come back. The question is, when is it going to come back? It could be 5 years from now or 10 years from now, but patients who have lone AF generally continue to have it. And so, but the one thing you can't predict is how often. Now, the interesting thing is it used to be believed that if you had lone atrial fibrillation, that somehow that increased your risk for long-term chronic atrial fibrillation. That, in fact, is not true. One thing that we probably should consider in this patient, though, is an EP study looking for the presence of an SVT mechanism that could be triggering her into AFib. But I think the first thing that some people would want to see more than one episode to do that. We wrote a paper on this, and there have been other studies that have suggested that in kids, it's probably anywhere between 10 and 30% of kids who have AFib have SVT as a triggering mechanism for it. So to me, that's a high enough percentage that it's probably worth an EP study. So I probably would do a 14-day ZO to confirm that there's no illicit or unrecognized AFib. And if the patient is in sinus the entire time, then I might actually probably recommend doing, I would of course advise against alcohol if the alcohol had anything at all to do with this episode, which I do not believe it did in this particular case. And then I would probably consider doing an EP study, a limited EP study, just to rule out the presence of an SVT mechanism, because in most studies, when SVT has been ablated, it is very uncommon for the AFib to recur, at least in the short to midterm. So that's pretty much how we would think about a patient like this. Okay, thank you. Let's do this. Actually, I like this question even the best. Okay. So this is an adult Fontan patient. And we're going to play Name Your Leads. Lots of stuff on this patient. So this is a single ventricle patient who I think has hypoplastic left heart syndrome. So I'm going to ask Dr. Barris. So Dr. Barris, I'm going to point at different structures in here, and you're going to tell me what we're looking at here. So what is this lead here? What do you think this is?
That looks like an atrial lead.
That's right. This is a bipolar atrial lead with the two poles right here. And what do you think about, we've got these and these and these. What do you think these are?
So those are ventricular leads. I guess the one all the way on the bottom could be an RV lead.
Right. So this is interesting. This patient has 3 sets of ventricular leads. And this is important because it just demonstrates how fragile pacing leads are when they're epicardial. This patient has needed 3 sets of ventricular leads during their lifetime already, and they're only in their, I think, early 30s. So this is a nice demonstration of how fragile the epicardial lead systems are. What is this here? What is this lead, Dave?
That one, I'm wondering if it's going to the RVOT.
Okay. In a single ventricle, would we normally put a lead in the heart?
No.
No. And it's
So I guess-
attached, I'll tell you, it's attached to this device here, which is
So I
a
guess,
good hint.
so is it an ICD lead?
Yeah, this is an SICD lead. And then, but you notice the patient also has this pacemaker. So this is a young patient who has both an SICD and a epicardial pacemaker. And we're seeing this increasingly in Fontan and single ventricle patients. The nice thing about an SICD for a Fontan patient is that the system doesn't have to go in the vascular space. It's all subcutaneous. And so if the patient needs a defibrillator, this is a very nice opportunity to use a subcutaneous ICD, as long as they pass the EKG testing, meaning that they have a nice signal that the device can read, because this lead essentially is like a lead of an EKG monitor for the sensing. And it's essentially using effectively an EKG lead to send the data to the device instead of using an actual pacemaker lead. And then the last thing I'm going to just point out, which I think is interesting, is you see these things, the sort of, there's actually, this patient has, actually I'm wrong. Those are just the backs of these leads. No, I think I'm right. These are actually, there's some, no, I'm wrong. These are just the leads themselves. So this is just an example of which we're going to see increasingly of a single ventricle ACHD patient who has both a pacemaker and an SICD. We now follow, I think, 3 of these patients. One of the interesting aspects is, you have to pass this algorithm that Boston Scientific has for an SICD, and some patients don't pass it, meaning that they are not candidates for SICD, because the system is thought, the test is to tell whether or not the system will be able to discriminate the ventricular rate adequately. And in those patients, we are in a lot of trouble. And a classic example of that is Epstein's anomaly, where a high percentage of those patients, unfortunately, are not candidates for an SICD. We always test them, but because their QRS morphology can be small and their atrial morphology very large, sometimes they fail the screening, and then they're not candidates for SICD. As you would imagine, you wouldn't really want to put a pacemaker lead across the tricuspid valve in somebody with Epstein's anomaly. All right, I think we'll stop here. Thanks, guys. I will see you at sign out in just a short while. Have a good day.
Thank you.
Bye.
Thank you.